Pityriasis alba, welcome to this detailed lecture on pityriasis alba. Imagine this, a concerned parent brings in their child with pale, scaly patches on the face. They are worried. What could it be? Is it something serious? Pityriasis alba, also known as PA, is a common yet benign skin condition that often raises such concerns. Derived from the words pityriasis, meaning fine scaling, and alba, meaning white, this condition presents as hypopigmented, scaly patches, mostly affecting children and adolescents. Though PA is self-limiting, its appearance can cause significant cosmetic concern, particularly in individuals with darker skin tones. Today, we'll explore the causes, clinical presentation, diagnostic approaches, and treatment strategies to help you manage this condition effectively and confidently. Etiology. Now, let's dive into the why behind pityriasis alba. While the exact cause remains unknown, the condition is believed to stem from several key factors. Skin barrier dysfunction. An impaired epidermal barrier leads to increased transepidermal water loss, making the skin dry and vulnerable. Post-inflammatory hypopigmentation. Subtle inflammation or prior eczema interferes with melanogenesis, resulting in the characteristic pale patches. Atopic predisposition. Pityriasis alba is often seen in individuals with atopic conditions such as dermatitis, asthma, or allergic rhinitis. Environmental triggers. Sun exposure enhances the contrast between normal and hypopigmented skin. Frequent washing or use of harsh soaps exacerbates dryness. Age and hormonal factors. This condition predominantly affects children aged 3 to 16 years, likely due to their developing skin physiology. Nutritional deficiencies. Some cases may be linked to deficiencies in iron, zinc, or vitamin D, though the evidence remains inconclusive. History. The history of pityriasis alba often unfolds with subtle clues. Onset. Lesions develop gradually and are usually first noticed after sun exposure when the contrast becomes more evident. Symptoms. PA is typically asymptomatic, though mild pruritus or dryness may occasionally be reported. Chronicity. Lesions can persist for weeks to months and frequently relapse, especially in atopic individuals. Associated conditions. A personal or family history of atopy, such as eczema, asthma, or allergic rhinitis, is often present. Social and environmental factors. Overwashing, irritant soaps, and sun exposure are common contributing factors. Clinical findings. When you examine a patient with pityriasis alba, you'll notice distinct features: cutaneous manifestations, primary lesions, hypopigmented macules or patches, measuring 0.5 to 5 centimeters in diameter, with poorly defined borders. Scaling. Fine, superficial scaling is visible, especially on close inspection. Distribution. Lesions are most commonly found on the face, particularly the cheeks and perioral region, but also appear on the upper arms and trunk. Color variation. The hypopigmentation is more noticeable in darker-skinned individuals or after tanning. Complications. Persistent hypopigmentation can lead to cosmetic concerns or psychological distress. Differential diagnoses. Vitiligo, sharp depigmentation without scaling. Tinea versicolor, scaling hypopigmented or hyperpigmented patches with a positive KOH test. Post-inflammatory hypopigmentation, history of trauma or inflammation. Leprosy, hypopigmented patches with anesthesia. How to diagnose. Diagnosing PA is straightforward, often based on clinical evaluation. Clinical diagnosis, recognized by its characteristic hypopigmented, scaly patches. Wood's lamp examination. Subtle fluorescence can aid in differentiating PA from conditions like vitiligo. Microscopic examination. Potassium hydroxide, KOH. Tests help rule out fungal infections such as tinea versicolor. Skin biopsy, rarely needed. Histopathology may show mild spongiosis, perivascular lymphocytic infiltrate, and decreased melanin content. Management. Managing pityriasis alba requires a multifaceted approach aimed at alleviating dryness, minimizing inflammation, and addressing cosmetic concerns. Non-pharmacological measures. Skin hydration. Emollients containing ceramides, urea, or glycerin should be applied regularly, especially after bathing. sun protection, use broad-spectrum sunscreen, SPF 30, to reduce contrast between normal and hypopigmented skin. Gentle skin care, mild, fragrance-free cleansers should replace harsh soaps, and overwashing should be avoided. Pharmacological therapy. Topical corticosteroids, hydrocortisone 1% cream applied twice daily for 1 to 2 weeks is sufficient for mild inflammation. Moderate potency corticosteroids like mometasone furoate 0.1% for resistant lesions. Calcineurin inhibitors, tacrolimus 0.03% or 0.1%, applied twice daily, is an excellent steroid-sparing option for facial lesions. Keratolytic agents, lactic acid or salicylic acid moisturizers can help reduce scaling. Systemic treatments, rarely needed. For severe cases, antihistamines like cetirizine 10 mg per day may be prescribed for associated pruritus. Phototherapy, narrowband UVB can aid pigmentation in recalcitrant cases. Advanced therapies, vitamin D and zinc supplementation can be considered in cases with confirmed deficiencies. Treatment algorithm, mild disease, focus on emollients, gentle skin care, and sun protection. Moderate disease, add low-potency corticosteroids or calcineurin inhibitors for short-term use. Severe or recalcitrant disease, consider phototherapy and address nutritional deficiencies. Conclusion, Pityriasis alba, while benign and self-limiting, is a condition that can cause significant cosmetic and psychological concerns. Early recognition, patient reassurance, and effective management are key. With simple interventions like emollients, sun protection, and topical anti-inflammatory agents, we can significantly improve outcomes. As dermatologists, our role extends beyond treatment to providing the reassurance and guidance that